Amy, you ready? Good afternoon, everyone. Today is Thursday, January 25th. You are in the Finance Committee, and we are looking forward to two presentations today. The first, which will be the MHA Hospital Throughput Work Group, and we're going to hear from Brian Sims and Dr. Neil Verbacher. So if you'll come to the table, please. Thank you.
Good afternoon, all, and thank you for having us. Madam Chair, if it's okay, I can do the presentation from the podium. Is that okay? Thank you.
Is it okay, Tammy?
Yeah.
Okay. Got it. Just want to make sure. Okay. All right. Good afternoon, members of the Senate Finance Committee. Good afternoon, Madam Chair, Madam Vice Chair. My name is Brian Sims. I'm the Vice President of Quality and Equity at the Maryland Hospital Association. And before I get started, I want to share my greetings from my colleague, Aaron Dorian, who has really been working hard on this emergency department issue, who is dealing with a family emergency. And so I do want to acknowledge all of the really hard work and leadership that she's shown on this issue. And her apologies that she couldn't be here today. I'm here representing Maryland's 60 hospitals and health systems and the more than 100,000 employees who go to work every day to care for Marylanders across the state. And so again, I want to thank you for an opportunity today to update you on some of the work that we've been engaged in to address the serious issues that our patients and staff face in hospital emergency departments around the state. And so as we get started, I want to provide some context around some of the things that we will be discussing. So we think of our emergency department as an important access point. Maryland's emergency departments care for more than 1.7 million patients a year, providing an important access point for many Marylanders. And as you see here, that is almost the population of the entire state of West Virginia. So data shows that nearly 90% of these patients are discharged from the ED, which means that at that time, they did not need to necessarily be admitted into acute care. But that's not to say that these patients didn't have an urgent issue or that they had other options to access the right care at the right time. And so unlike many alternatives to care for lower level ED visits, hospital EDs are open 24 hours a day, 7 days a week, 365 days a year, and care for anyone who walks through their doors. The emergency department is more than just a front door to the hospital and is, in fact, oftentimes a safety net provider for those patients that frequent the ED in many instances. And so over the past year, we spent a lot of time talking about how long it took for a patient to walk through the door, to be triaged, and the wait to be seen, treated, and discharged. And Maryland does rank last among states in the U.S. in the average amount of time that all of that takes. Though there are many successes that we are very proud of on behalf of our hospitals and our members, we want to perform better on the ED wait time issue. We must perform better, and we are fully aware of that. And so what we are here to talk about today is how we have all been and continue to work together toward the goal of reducing Maryland's emergency department length of stay and improving overall hospital throughput. And so as we talk about that work, I'm going to walk you through a little bit of a timeline, and you all have the materials here, and we have some printed copies as well. So I'm not going to read through each of these. But before I go over what the stakeholder work group process has yielded and what that process looked like, which was requested by the chair of the ACO and the previous chair of this committee here, I want to take a moment to update you on what the hospital field is doing and has been doing collectively to solve this problem. And this work goes beyond what individual hospitals and health systems have been doing internally. And in a few minutes, you're going to hear from my colleague, Dr. Neil Verbacher, a bit more of a clinical perspective on the wait time and throughput issue. But I want to emphasize that the solutions that we are seeking extend beyond the focus of the ED. And we've talked extensively about the healthcare workforce issues that we face over the past several years, which undoubtedly is impacting the patient's abilities to access care and the hospital's ability to move patients through the ED. And so we partnered with members of the General Assembly since 2021 on developing solutions to address our workforce crisis through MHA's task force on Maryland's future healthcare workforce. Last January, we at MHA launched our Join MD Health digital campaign, attracting individuals to careers in healthcare and also efforts to retain current staff. So I encourage you all and for you all to share with your constituents to visit the joinmdhealth.org site and take the quiz to find out if you are a head, a hand, or a heart, which is the theme of our effort. So on to the ED specific work. First, in May 2023, MHA launched a 10-week learning collaborative on ED crowding, or a sprint, where we had a nationally recognized expert work with our hospitals in identifying some best practices and some barriers and issues that could help overcome some of those barriers. Then in July, under the leadership of Dr. Malik Joshi, CEO of Meritus Health, in his role as an HSCRC commissioner, the HSCRC launched the Emergency Department Dramatic Improvement Effort, or the EDDI, which many of you are familiar with. And in August, MHA launched a Performance Improvement Collaborative, which has been led by my colleague, Aaron Davis, in here somewhere. This Performance Improvement Initiative will run through July 2024. And at that time, we expect to learn more about what works and what is needed related to hospital-centric efforts. And so now I want to talk a little bit about the stakeholder work group process that was requested by the chairs. And I want to first begin by thanking Chair Beidel and Senator Karen Lewis Young for their active participation in these work group meetings over the last several months. The work group consisted of 27 representatives from hospitals, provider groups, and consumer groups, patient advocacy groups as well. And so we met from July through the beginning of this month. Typically, we met in person. This last Friday was our final meeting that was held virtually due to the weather. And in October, MHA brought in Health Management Associates, or HMA, a leading healthcare consulting firm, to assist in the group's efforts as we move towards recommendations, and also to bring in some additional expertise given the complexity of this issue. And one thing I want to say I think is really important is that, as you all can understand with any complex issue, it's an issue of not only the reality of what's happening on the ground, but the perception that people's experience and face when they are engaged in this process or engaged in needing services from our emergency departments. And so you'll see that much of the work that we've done not only addresses the reality, but it's also important to communicate to patients, issues that address their perception. So, one of the things that I think is really important is that there were a lot of things that have been discussed in this process. And so among many of those issues, the work group identified 4 top issues contributing to longer ED lengths of stay in Maryland. And you see those here: hospital capacity and emergency department boarding, the behavioral health crisis, the ongoing behavioral health crisis, which we have talked about in front of this committee and others before, healthcare workforce shortages, which I've mentioned already, and limited access to care and resources outside of the ED that could otherwise reduce the need for urgent or emergent care. And so
Excuse
these
me,
factors,
Brian,
oh, sure.
will you explain what boarding is to the committee?
Yeah,
Thank
and we're gonna there's another slide where I have some data on that. But boarding is patients who need to be admitted, who come through the ED, who ultimately need to be admitted. A physician has decided that they need to be admitted, but there are delays or bottlenecks throughout the hospital that limit their ability to move to the floor or the unit that they need to move to at that time. And so they are boarded, or they are held in the ED until a bed becomes available. And so, of course, these factors exist in other states around the country. And there are some specific ways that Maryland is unique that may explain some of the pain points experienced in Maryland's EDs more acutely than other states. And so we're going to talk about that a little bit. And one of those issues is hospital capacity. And so when we talk about hospital capacity, we're talking about the total number of hospital beds in the state. But more importantly, it's the total number of staffed beds. How many beds are staff able to care for patients in? And obviously that has been impacted by the workforce crisis that we've already emphasized. And so these, staff beds, or the number of beds that are ready to receive a patient, again, contributing to that boarding issue, Chair Vital, that you just mentioned. And so what you're looking at here is the raw number of total beds on the left. And you see that in Maryland, we've seen an overall decline since 2015. And these are some of the goals of our model to reduce what we consider potentially avoidable utilization throughout our hospitals. We've seen an overall decline in total hospital beds, also a factor or function of the workforce shortages. But we're seeing a little bit of an uptick since 2019. However, we have not reached the level from almost 10 years ago. And on the right-hand side, you will see that Maryland has the 5th lowest number of hospital beds per 1,000 population in the nation. And many of our docs will admit that this is contributing greatly to this issue. Another issue that some data can really work to highlight is hospital occupancy. Several work group members have highlighted hospital capacity, occupancy, and the correlation between the two as it relates to ED boarding and other factors that contribute to extended ED, emergency department lengths of stay. And to be more specific around a definition of hospital boarding as defined by the American College of Emergency Physicians, it is the practice of holding a patient in the emergency department after they've been admitted to the hospital because no inpatient beds are available. So I wanted to share that formal definition. And so this slide shows the 7-day average staffed occupancy rates across all hospitals in the state, as well as the total number of ED boarders across all hospitals in the state. And you see that they generally trend in the same direction. And so I think it's also worth noting that in a paper published in the New England Journal of Medicine, several chairs of EDs at academic medical centers discussed the relationship between hospital occupancy, ED boarding, and they concluded that at occupancy rates over 85%, ED functional space will be reduced, that space that patients can be treated in. And there will be higher levels of patient boarding, so patients being backed up in the emergency department. And these patients that we're talking about, these boarders, do need acute care. So these are not the 90% that likely can be discharged without admission. These are patients that need to be moved throughout the hospital. You know, and as you can see, for the majority of 23, for at least the second half of 23 per this data here, hospitals throughout the state have been above that 85% threshold per that green line there at the top. And so we know that behavioral health visits contribute greatly to not only the emergency department utilization, but also those patients that spend an extended amount of time in our emergency departments. And work group members have discussed how the behavioral health care crisis in Maryland contributes to the ED length of stay and hospital discharge challenges. And as you can see here, the ED visits for behavioral health related issues continue to rise. And so these are admissions for patients that had a primary diagnosis of a behavioral health admission. But one of the things that we have found is that a large plurality of ED visits also have a co-occurring behavioral health condition. So just something to keep in mind. And so I do want to thank members of the General Assembly for the work that has been done on this issue over the past several years, including the passing of a bed registry bill, which has increased visibility into the availability of psych beds, and the creation of a commission on behavioral health care treatment and access, and other bills that seek to improve the crisis services and many other things. We know that there's still a lot of work to do, and we look forward to continuing this really important work. As I mentioned, the workforce crisis, one of the things that you see here are the top 10 hospital occupancies by vacancy rate. This group, the stakeholder work group, discussed the importance of addressing the healthcare workforce crisis extensively, but acknowledged that the Workforce Commission that was passed 2 years ago is coming up with a comprehensive set of recommendations. And so we didn't want to overlap with existing streams of work, but we do want to identify ways that we can build off of those things. And so without intervention or continued intervention, these shortages can be and are expected to continue to grow. And these shortages not only impact the patient's access to care outside of the hospital, as you see, the spectrum of the workforce spans not only with inpatient care, but also all of those services that are necessary for a healthy and well population. But it also impacts the hospital staff to fully meet the volume of patients that we are seeing around the state. And so now I want to get to the work group recommendations, and just kind of a preview of these. As I mentioned, we had our last meeting last Friday, not quite a week ago. The group is working on finalizing what those recommendations are, and the report, which you all will, it will be shared with you all in February sometime. But I want to preview these recommendations with the caveat that, again, we're still finalizing those. And to remind the group that HMA has been engaged since October to independently facilitate the aggregation and identification of these recommendations. And so this was done over several months, that since, let's say, July. And so the different areas of work that the recommendations fit in can be categorized by these 4 categories here: statewide process improvement, access improvements, workforce recommendations, and some additional recommendations that didn't fit perfectly into some of these. And I'm not going to read all of these in detail, but I do want to just give you some of the things related to some of the higher priorities that were identified through a process where stakeholder work group members voted on these recommendations. I'm sorry, my iPad is jamming up now. Give me 1 second. I think it's trying to connect to my Wi-Fi back at the office. Give me 1 second.
Probably better than our Wi-Fi here.
Maybe that's the problem. I didn't, you know what? That's why I brought some redundancy. So you know what? Listen, I'll tell you, Senator Bidle has been a part of this process. It's been a lot of work. It's a very sensitive topic. And it's something that, we're proud of the work that we've done. We're proud of the partnerships that we've created and the folks that we've worked with. We've worked with some non-traditional partners on this. And so, it's really been something, it's been a pleasure working with the folks, but it's been tough work. And so a little more about what that process has looked like. HMA conducted informant interviews of state leaders, a consumer advocate, and hospital leaders, and 2 emergency room site visits were conducted so they could see some of the things that have been discussed in this process. And so over 2 meetings, the work group broke into subgroups to identify and develop these potential recommendations. We figured that there was more fruitful conversation by doing it that way and then bringing everybody back together. And so along with the recommendations that were developed formally by the group, we distributed a questionnaire in mid-October to work group members to solicit potential solutions. 7 members submitted 17 solutions, and these responses, along with the output of the work group deliberations, were condensed into 28 individual recommendations and presented to the work group. So again, what you see here is just a snapshot of some of the high level areas of the recommendations. The 4 categories that I mentioned, again, were, very broad. The conversations were very intricate. And so under the statewide process improvement, the group discussed additional data tracking that providers in the state could use to partner to collect and analyze and understand some of the hospital system throughput issues and concerns. In the access improvements category, there was significant conversation around making sure that every Marylander has access to health insurance. And these are efforts which MHA has supported in the past, and we continue to support this year as well. Under workforce, the group reaffirmed a recommendation from the Workforce Commission that data on the healthcare workforce shortage should be collected in a systemic way. And last, improving the guardianship process was of particular importance to the hospital representatives around the group, as patients are sitting in hospital beds for months and sometimes up to a year who no longer need acute care, but are waiting for the courts to make a guardianship decision. And so we will be supporting legislation aimed at improving the guardianship process to facilitate faster discharge decisions at hospitals. And I want to thank Chair Bidle for really leading the charge on this issue and agreeing to sponsor a bill, which I understand is in the works around the guardianship issue. And finally, I want to acknowledge that while some of these recommendations may require action on the part of the legislature, many of these recommendations will not require any such legislation. And so, that is one of the things that we are proud to have worked out, some recommendations that can happen more expeditiously on behalf of Marylanders. And so before I hand over the presentation to my colleague, Dr. Vibhakar, I want to let you know that you can use this QR code here. You can share it with constituents and stakeholders to find all of MHA's resources on this hospital throughput and emergency department length of stay issue, including the materials from the work group meetings and recordings of each meeting. And so with that, I will turn it over to Dr. Vibhakar, and I look forward to any questions you may have afterwards. And I think you can, yes.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Neil Vibhakar, and I have the pleasure of serving as Associate Chief Clinical Officer for the University of Maryland Medical System and the Chief Medical Officer for the University of Maryland Baltimore Washington Medical Center. Thank you for the opportunity to share how the University of Maryland Medical System is approaching emergency department wait times and hospital throughput. I'd like to start our conversation with a discussion on the root causes of emergency department wait times. If we were to picture the emergency department as a roundabout, there are minimal barriers when each exit off that roundabout is home. Very rarely would an emergency department be overwhelmed if every patient went home. Once the care is delivered and the patient is treated, it only takes about 20 minutes for that patient to leave the room and be on their way home. The bed is quickly turned over and then ready for that next patient. As a result, focusing solutions on decreasing the volume of discharged patients will not have an impressive impact on the overall emergency department wait times. However, when you introduce an inpatient bed as one of those exits, it can create a backlog of patients in the emergency department. This has an impact on all patients awaiting care, whether they need to be admitted or need to be discharged. The backlog occurs due to a number of factors, including staffing, higher acuity, longer lengths of stay, complex social and chronic conditions, and transitions of care outside of that hospital. The impact of boarded patients can be profound. Patients waiting for a hospital bed can stay in the emergency department 3 times longer, sometimes even longer than that. While a hospital may admit only about 20% of the patients that come through the emergency department, those admitted patients can occupy 50% or more of the beds in the emergency department. And finally, if we presume that a discharged patient takes about 3 hours to evaluate, diagnose, and treat, we could see about 8 discharged patients in that space for every 24 hours an admitted patient sits in the emergency department. So as you can see, the impact of boarding has a disproportionate impact on wait times in the emergency department. In understanding this workflow, emergency department wait times are being tackled in 2 different ways. Knowing that the majority of root causes live outside the emergency department, we as a hospital industry have engaged our inpatient and our outpatient colleagues to improve overall throughput. And these are just a few of the examples. The surge response plans allow for a systematic approach to be certain all interventions are being considered. Care transition rounds ensure we have a safe handoff from the hospital to home. Standardizing care minimizes variation and provides evidence-based algorithms for our teams to follow. Creating an expediting team has helped address barriers such as getting a radiology test, a physical therapy evaluation, or physician consults to reduce the length of stay. And a departure lounge provides patients a convenient, safe place to wait for their ride after a discharge from the hospital. And finally, close outpatient follow-up reduces the likelihood of readmissions back to the hospital. Now, knowing that the inpatient and outpatient efforts are often longer-term strategies, we are also looking to make an immediate impact with changes in each of our emergency departments. Vertical care allows us to care for patients who do not require a bed. An enhanced emergency department discharge program provides resources for patients that can then be safely discharged from the emergency department rather than being admitted. Rapid medical evaluation initiatives allow for patients to be quickly assessed and have studies ordered while they wait. And observation medicine attempts to complete full workups in the emergency department on patients that would have otherwise been hospitalized. While it'll keep the patient in the emergency department longer, it does preserve an inpatient bed if they can be discharged directly from that emergency department. At the University of Maryland Medical System, we have seen the value of being engaged on this work at the state, system, and local levels. Through the General Assembly Hospital Throughput Work Group, and the MHA Throughput Collaborative, there's been a multidisciplinary approach to identifying root causes, developing solutions, and sharing best practices. While this presentation is about what UMS is doing, I can say with confidence that every hospital across the state is doing great work and is focused on making improvements. At the system level, we have created a standardized surge plan, created urgency through an executive level throughput summit, and now have committees that meet on a bi-weekly basis addressing patient flow. And finally, at the local level, each hospital has a patient flow council that focuses on emergency department, inpatient, and outpatient interventions. The system coordinates its efforts through subcommittees that meet bi-weekly to share best practices and implement new ways of delivering care, through sharing of how each hospital is doing each day in terms of capacity, staffing, and volume through a bi-daily report, and finally, through standardizing our approach to dealing with high volume days. What you'll see here is just an example of certain steps each of our hospitals can take in addressing their surge response. At a level of Charlie, we are notifying the organization and shifting the focus of certain staff. At level Delta, we are potentially reallocating staff to where the needs are greatest. And at level Echo, we are thinking very differently, potentially canceling meetings and using alternative spaces to care for our patients. Now, it's clear that solving the emergency department wait times will not be accomplished by one singular intervention. It will also not be solved without the help of every single person and department that touches patient flow. So given the magnitude of the challenge, it can be daunting and sometimes difficult to grasp how we can make such an impact. So this is where the concept of a moonshot goal came about for one of our hospitals, Baltimore Washington Medical Center. It might be hard for certain departments to realize how they can help improve emergency department wait times, but they do know how they can improve processes in their own departments. And by reducing length of stay, you create more bed availability with the existing resources you have. So we challenged our leaders to create 30 beds of capacity through more efficient processes in each of their departments. And as you may be aware, there's been a significant focus on the aim statements that have been submitted by each hospital. The aim statement is intended to demonstrate an initiative and goal to improve ED wait times. While one aim statement can help, we believed it was going to take a fleet of aim statements to make an impact. And those departments definitely delivered. I highlighted the ones in yellow just to demonstrate how so many different departments, inpatient and outpatient, can play a role in creating bed capacity and ultimately improving ED wait times. So the examples here come from the inpatient units that are looking to improve the number of patients coming through the departure lounge, the operating room, creating a process to perform more same-day surgeries rather than waiting for the next day. The outpatient practices, creating a clinic for very close follow-up so we can avoid a readmission to the hospital. The pharmacy department, looking to see which patients can be converted from intravenous antibiotics to oral antibiotics. And the emergency department, expanding their successful rapid medical evaluation program to be able to take care of more patients that need to go home. It's going to take a village, and this is an example of how that village is coming together to help address emergency department wait times. And so now when we look across our entire medical system, there are several initiatives that have gone into place that have begun to demonstrate an improvement in a variety of metrics. At Baltimore Washington Medical Center, as I mentioned, we've implemented an expediting team in departure lounge. We've also initiated a rapid medical evaluation program that has resulted in a 24% improvement in early discharges and 51% improvement in reduction in the emergency department left without being seen rate. Charles Regional has developed a split flow care model in their emergency department to help with care for those dischargeable patients. And they've partnered with EMS to improve EMS offload times. They've seen a 12% improvement in EMS turnaround times and a 33% reduction in the patients that leave without being seen. At CAP Region, they've also implemented the surge plan that we have across the system, and they too have created an expediting team, demonstrating the ability to share practices across our system. And they've seen a 63% improvement in discharges prior to noon. At the Shore, they've implemented a nurse-driven protocol to facilitate telemetry usage reduction. Those are beds that are in high need, and so moving patients off their needs for telemetry can help create increased capacity. They've also revamped their patient and transition rounding to improve communication and improve overall throughput. So they've seen a 33% reduction in the time from when a patient is waiting from an inpatient bed to when they get upstairs, and a 32% reduction in telemetry utilization during that time. At St. Joe's, they developed a dyad physician and nurse partnership across the organization to lead length of stay initiatives across each of their departments. And they've also started to use predictive modeling to better predict when a patient will be discharge ready and how to best prepare them. They've seen almost a half a day reduction in their length of stay and a 40% reduction in their emergency department left without being seen rate. And at Upper Chesapeake, they've developed an enhanced emergency department discharge program, as I mentioned earlier, and they also opened a departure lounge for their patients and have seen a 33% reduction in the number of observation patients requiring hospitalization. And finally, University of Maryland Medical Center, both the downtown and midtown campus, have created a real-time process to improve the skilled nursing facility transfer process. And they've also implemented a vertical care process to care for their discharged patients. And finally, they've partnered with EMS to improve the offload process so the EMS paramedics can get back on to the streets. They've seen a 35% reduction in EMS offload times at the downtown campus and a 45% reduction in emergency department left without being seen rates at the midtown campus. And so while we are proud of these results, we know that there's still more work to be done. We plan on continuing to focus on creating inpatient capacity, on ensuring safe and timely follow-up. We will not compromise quality for speed. Continuing with emergency department interventions to care for the discharged patients, and partnering with our others outside the hospital, including post-acute care facilities, to improve transitions of care. So I'd like to close and personally thank the committee's engagement and interest in this topic. I'm an emergency medicine physician, and I've seen the impact of emergency department wait times across my 20-year career. I'm encouraged by the direction the state and our hospitals are going to address this important issue. Thank you very much.
Do I have questions? Senator Ellis.
Yeah, thank you, Madam Chair, and thank you, gentlemen, for your briefing. So I have like 3 questions, and I think they'll be short. They're important to my constituents. On page 9, you talked about, there's a chart that talks about nurse vacancies from Eastern Shore 4.9% to Southern Maryland. Is that a 30.6%? The number
Vacancy rate.
vacancy, and that's in the just the ED or all over the hospital.
Throughout the hospital, registered nurse vacancies throughout the hospital per
Yeah.
region. Yeah.
Okay, so I represent Charles County
Mhm.
here, and that's of particular concern to me. So why is that number so much higher than, say, Eastern Shore at the lowest 4.9%?
Yeah, I don't want to speculate too much on that. And we may be able to get some more detailed answers back to you. But again, the healthcare workforce shortages were exacerbated by the pandemic, and we know that the Southern Maryland region was hit particularly hard as well. And it's also a function of, where were the vacancies? What was the vacancy rate prior to the pandemic versus what is it now? So, how has that trended? So that's important to note also. One of the things that we're seeing is not only are people, simply not entering the professions as much as they used to, but they are leaving healthcare altogether. And so in areas where there are other options and alternatives, that could be contributing to it, but we definitely would have to look into that a little more. And Dr. Vibakar might have some insights into why
Yeah,
you have a
thank you.
regional difference.
I was going to ask you to, because the hospital in Charles County is University of Maryland Medical System. And so why is that such a high percentage in Southern Maryland region? And I assume that involves the hospital in La Plata also, that the high percentage vacancy like that with nurses.
Yes, I'd have to defer to the specifics to the leadership at Charles. But again, I would agree with Mr. Sims here. It has been a challenge across the state. Some of our areas have been impacted more than others for a variety of reasons, whether it is the ability to recruit into that space or as Mr. Sims said, folks leaving the profession. Nursing has the opportunity to work in a lot of different fields, both inside and outside the hospital, and both at the bedside and outside the bedside in administrative opportunities.
Yeah, I understand that, but the key is look at the overall statistics. And so when you look at 4.9% on Eastern Shore, 30.6% in Southern Maryland, my constituency, that's a huge disparity. And you just can't say overall workforce. There's an issue going on in Southern Maryland. And I would follow up with you to find out exactly what, because healthcare is very important to all of us,
Yes.
especially to us in Southern Maryland. And so I look forward
Would be
to
happy to follow up
get
with
some
you. Yep.
details with you wherever we can get that
Sure.
from. Thanks. And one more question, well, 2 more. Vertical care, you mentioned vertical care on a chart. And what's vertical care? I mean,
Sure, be happy to explain that. So many patients that come to the emergency department require a stretcher, a bed, because of how sick they are. There are other patients who don't need that. They literally can stay vertical. And so that's a term that they use to be able to care for patients who might come in for a sore throat or an ankle sprain, something that doesn't require a stretcher, that we can then reserve those spaces for the patients that
Right.
need.
Thank you. That was quick. And last question,
Yes.
page 21, you talked about on page 21 of the chart, you talk about you were proud of, say, in University of Maryland Charles Regional Medical Center, 33% reduction in ED left without being seen. So that's a reduction in people leaving without seeing. What's the number? I'm curious. How many people leave the ER because they couldn't get to a physician?
Yeah, so that varies from department to department. The industry standard says that you're left without being seen from emergency department should be around 2 to 4%. And so each of our hospitals has seen challenges with that as the boarding patients take up a lot of the beds in the emergency department. The patients get tired of waiting and will leave. And so each of our hospitals, including Charles, has put processes into place to reduce that left without being seen. So Charles has seen a 33% reduction. I'll have to go back and see what the baseline number was.
If you could follow up with me with that also, please. Thank you.
Sure.
Thank you, Madam Chair.
Thank you, Senator. Senator Kramer?
Thank you, Chair. Quick question. I recently had a conversation with a regional hospital surgeon who told me he was going to be leaving the hospital because he was pretty much burned out. And he indicated that the problem was that the hospital was constantly monitoring the number of surgeries he performed during a monthly basis and would tell him he had to do more surgeries in order to maintain hospital profits. Is that a standard practice within our regional hospitals in the state? He said he would get these letters indicating you only did 3 of such and such a surgery during the course of the month. You should have done X number. The expectation is you will be doing so many of these surgeries. And I had never known that such practices exist. And he indicated that that is the standard within our regional hospitals. Could you maybe just share a little insight for me on what that's about?
So I can't speak to that specific scenario. That is not how I would approach a concern about volume. At the very least, what I would say is we need to do surgeries, provide the care for the patient that needs them. No more, no less. I do not believe, it is our goal to perform surgeries for the sake of performing surgeries. It should absolutely be centered around the patient and the care that they need. So again, I can't speak to the specific surgeon's experience, but if it's at any one of our University of Maryland Medical System hospitals, we'll be happy to follow up with you. To your first point around the burnout, I think that is real.
Well, but no, please, I get the burnout.
Yeah.
And but that was clearly not my question. My question is, are you all at all familiar with this being a policy at regional hospitals? And would you maybe, I saw you're going to get some information back to the good senator from Charles. Would you be able to do an analysis of the practices at our regional hospitals and share with me if somehow this was absolutely inaccurate, or if this surgeon was correct that there are regional hospitals that are requiring the, maximize surgeries? Does it sound even remotely familiar?
Sure. So, I've worked inside of the hospital, some of the biggest systems in the state, some medium-sized hospitals, and I've been at the Hospital Association for almost 10 years now. This is not a policy that I've ever heard of. It's not a practice that I've heard of. But again, that's not to speak to that individual's experience. But the one thing I would remind this committee are the goals of our Maryland total cost of care model, which heavily incentivize the right care at the right time, at the right place. for necessary care. And in fact, our model has really been the example that the federal government is using to expand on that around the country. So, you know, I just wanted to add that context. And as far as your request for information, we can look into whether or not that's something that's feasible and get back to you. There are different operational and leadership structures, and where that message may have come from, it might take some doing to figure out. But
So let me take a slightly different
Yeah.
tactic on this. Would you all support legislation that prohibited any hospital from having any kind of requirements or standards for numbers of surgeries? In other words, if it's your representation of the committee, this is not a common occurrence and you're not aware of it being a practice, would you all be comfortable saying, yeah, you know what, if there was legislation prohibiting this kind of practice in our hospitals in the state, something you all would be comfortable supporting?
I can't imagine what that legislation would look like, and I don't really want to speculate here, but what I will say is that, you know, we wouldn't want to support anything that would get in the way of, as Dr. Babakar said earlier, high quality, necessary care.
Agreed. Okay, thank you.
Senator Reedy.
Thank you, Madam Chair. And this is a great presentation, and it's something that impacts, I think, all of our constituents have been concerned about. I have a local hospital in my county, and we've met and talked about some of these root causes and other issues as well, in addition to learning more about the process. On a couple of the slides from the first gentleman from your presentation, I was curious, as you look at the hospital capacity slide, how we're the fifth lowest in total number of hospital beds per 1,000 people. I guess when I heard that, I'm like, why? Because we've often been down here, we've always patted ourselves on the back as avoiding some of the things that have happened in some other states, especially rural states, where you have these unfortunate situations where hospitals are closing. You know, and we've had this whole model to make sure that doesn't happen. So did you guys explore why? I'm sure there's not just one reason, but why is that?
I can answer that, but Dr. Babakar, do you have any thoughts that you?
So either one, yeah.
Yeah. So, you know, I will say that, you know, the goals of our Maryland model, our total cost of care model, incentivizes hospitals working with partners and community-based organizations and stakeholders around the state to reduce acute hospital utilization. So that's part of the, you know, if we had a volume trend of hospital volume over time, you'll see that relative to the rest of the country, we have dramatically reduced volumes. Now, that doesn't necessarily reduce the need for capacity quite as much, because the patients that are left there are in fact sicker, and you can imagine that, right? Also, you know, the caveat on that slide, on slide 6, you know, under total hospital beds, we reference that as staffed beds. So, you know, the workforce crisis has an impact on how many beds can be staffed or ready to receive a patient. So it's kind of a couple of things going on. And then lastly, I'll say that, you know, just like Senator Ellis's point about the workforce shortages, you see a differential shortages around the state. Same thing with capacity and occupancy. If you look around the state regionally, you'll see that there are differences in utilization trends and occupancy around the state. And so, you know, some would say that, you know, there is low capacity in some places where there may be excess capacity others. And that is something that, you know, has been acknowledged, and something that we have been looking into.
As a follow-up, so we're doing a lot with workforce, and we know nursing shortage is a big problem. The hospitals, specifically why we're having trouble with having as many staff beds as some of these other states.
The other state,
because there's workforce challenges in probably every state with nursing. So go ahead.
Yeah, you know, I'm not prepared to answer that probably in the best way that you're looking for, but I will say, again, other states have different incentives for the way they operate. And to Senator Kramer's question earlier, you know, other states are not quite as incentivized as we are here in Maryland to reduce the total cost of care and to reduce unnecessary utilization. So, you know, there are a lot of differences in the ways that we operate relative to our other states around the country.
Okay. And then one final question, Madam Chair, on the chart, if I may, just on the hospital occupancy and boarding statewide. I noticed the spike, the chart goes back to June, and there's a spike here in the last month to month and a half. does a spike like that happen every winter cold and flu season, or is this an unusually high spike?
No, this is common for the winter. It has been a heavy respiratory disease winter with RSV, with flu, and even with a little bit of COVID.
Of COVID, yeah.
And so we do expect that, and we do see that routinely every winter. It fluctuates winter over winter, but yes, we do see that.
Yeah, I was curious. I assumed so, but also the challenge of having not enough staffing and enough staff beds is that it makes it worse when it does happen, obviously. So we all.
That's
wanna
right.
work on it.
I think,
Yeah.
the point is that infectious diseases like respiratory illnesses don't affect just our patients, but our staff as well.
Sure.
So they will go out, we will be short beds, a few 3-day weekends thrown into there as well. It becomes a challenge to move patients through the system, and they unfortunately end up warding then.
Well, thank you. I would love to, obviously, I think all of us want to work with you closely on figuring with some solutions and ways we can even look at maybe what some other states have done as well. If they're if some are having better luck, but like you said, it is a challenge across the spectrum. So thank you very much. Thank you.
Senator Washington, I'm going to ask you to do me, there you go. When you put your microphone down like I can't see your light. Tammy could, but I can't see your light. So you need to be careful when you're putting your light up to speak that you raise your microphone, if you don't mind. But Senator Washington, you're next. Thank you.
Whatever you need, Madam Chair, you got it. Thank you, Madam Chair. And just a question about this presentation. We talking about wait times, but there's nothing on here that actually speaks to the actual average wait time. I think you might have mentioned it. So can you just repeat what's the current average wait time in Maryland for our emergency rooms? But then also, yeah, if you could just give me that information, that'd be great.
What is it, 4 hours? Well, you know what, I'm not actually, so there is an average, but again, when you look at different, hospitals, different regions, that varies widely. And some of the root causes of that vary also. So apologies that is not in here, but we can get that number to you.
So we're just talking about emergency room stays.
Length of stay,
Length
yep,
of
so wait
stays.
time in the ED.
Wait time in the ED.
And it's important to think that there are a couple different ways that's measured. It's measured from when a patient walks through the door till the decision is made for whether or not they need to be admitted, from when the decision to be admitted is made to when they actually depart the ED. And so there are a couple of different ways to measure that. And
Is there a standardized method
There
that
are.
you all use? And if you can provide that to us?
we can provide it to you. Yeah, there are a couple different measures. I know Executive Director John Crum is going to speak about some things. The HSCRC has some policies and there are different definitions in that. So it might be helpful to bucket what those wait time measures are per the various policies and reporting efforts that are out there. So we can get that for you.
And I guess based on what's needed from the patient, is there a normal length of stay that the state should aim at and a hospital center should aim for, depending on that ailment that the patient has?
Dr. Babacar, do you want to talk
Sure.
about benchmarks or?
Yeah,
anything like
sure.
that?
Yeah, I think there's a lot of different ways to measure this. I think one of the unique things about Maryland is that we have so many different hospitals in so many different settings. And so part of what we would want to look at is improvement against themselves. And the incremental improvements they're showing through some of the efforts that they're making. And so that's where I would encourage us to try to look at it, as opposed to an apples to oranges comparison when we may be looking at a hospital in a city versus a rural environment, very different circumstances.
Absolutely. Okay. Last question, Madam Chair, if you don't mind. I'm going to University of Maryland system because it's in Prince George's County. And we have here a 63% improvement in discharges prior to noon. Is that a positive thing? Is that a good thing? Was it really bad before? And what does that mean?
Sure. No, that's a great question. And it's a good thing. So what happens in hospitals is that the needs of the organization and our patients start to occur around 10, 11 in the morning. The operating room starts to finish their first case. The emergency department starts to get busy. The challenge is that the patients that are discharged often are discharged much later in the day. And so the more we can push that time earlier in the day, the more we're able to keep up with the demand of the patients that are coming in. And we need to make sure we balance that with patients not just staying an extra night to get out early the next day. We want to make sure that that curve is basically moving to the left in terms of how quickly we're able to discharge patients without compromising the length of stay.
Thank you.
Senator Lamb.
Thank you, Madam Chair. Good to see you again, Dr. Vickbauer. I think we saw each other at the Anne Arundel County Legislative Breakfast earlier last month now. Question for it could be open to both of you, but you know, we've been trying to have multiple efforts to increase access to healthcare, and that includes folks that are undocumented as well. There have been a lot of discussions over the year about increasing coverage, insurance coverage, including for undocumented individuals in Maryland. Would, from your perspective, doing that actually help all of our constituents when it comes to the problem of reducing ED wait times?
What I'll say is this, and there's probably more that we can look into. It will have an impact, a positive impact over time for sure. In the immediacy, we know that pent-up demand, so folks who currently don't have access, when they have when they get coverage, they tend to seek access or seek services immediately. So there may be an increase, a spike up, but over time, absolutely yes. What's also important is, for patients, all patients, whether they are currently covered or will receive coverage under efforts to expand access to care, understand what they are entitled to across the spectrum of care, not just hospital care, but what they are entitled to from primary care and other services that can help to improve some of the conditions, particularly chronic conditions that they face that contribute to that excessive emergency department utilization. And so coverage is very important. It helps everyone, and not just those who will be newly covered. But it's also important that everyone understands, what are their alternatives to care? What are some other pathways that not only may help to improve outcomes, but also will be more convenient and accessible to those individuals?
Because if there are individuals that don't have access to, say, primary care because they don't have healthcare coverage, they end up using the ED as their primary care facility.
And they often wait until a problem has become even worse than it was originally. And so that's the need for increased care coordination and not only access to primary care, but building that relationship with that primary care physician so that they can understand through that trusted provider what their options are.
Okay. Second question, this pertains, I guess, more specifically to UMS, because you do have a Catholic hospital that's attached to the UMS system. There's a case that's now before the U.S. Supreme Court that could limit the coverage of EMTALA. EMTALA, for the rest of folks, is basically the federal law that requires the emergency departments to stabilize every patient that comes through the door before they're being transferred or sent somewhere else. This means that there are actually some real risks for hospitals that are no longer required to provide abortion care, for example. And even in the instance where it's needed to save the life of a patient. And there have been several women in other states that have died because they weren't provided necessary life-saving care in the emergency department. So my question is, what are we going to do to ensure that all Marylanders are able to access life-saving care, including abortion care, regardless of what location that patient is taken to by the ambulance?
So I can't speak to the specific case, Senator, but I can tell you that as an emergency medicine physician, and I think all of us in the field believe strongly that we want to be that catch for the community. We take pride in the fact that we will see patients, treat patients, and stabilize patients regardless of what's going on with them. That's what emergency medicine physicians do. It is why we went into the specialty in the first place. And so outside of that, I don't know if I can make any further comments to it, but we'll again say that I do believe that the field of emergency medicine takes pride in making sure that all of Marylanders are cared for emergently.
Yeah, certainly. And I agree. The providers, I think,
Yes.
have an oath to provide the care that's necessary to save an individual's life. I think it comes into question when there may be a hospital, say like St. Joe's, where because it's a Catholic-based hospital, may not be willing to provide abortion care. And a patient doesn't have a say in which hospital they're being transported to by the ambulance. And if they end up at St. Joe's and they need abortion care, they need abortion treatment, and they can't get it there, that could be risking their life.
Right. I'd be happy to follow up and to have this conversation with our leadership there.
Okay, thank you.
Thank you, Senator. Senator Mounts.
Thank you, Madam Chair. I wasn't gonna ask a question, but we're talking about staffing and nursing and it refreshed a memory of some hearings years ago. And there was a crisis because of paid leave. And I had not heard that come up, some of the employment requirements and things like that. Is that no longer an issue as far as staffing in running hospitals?
It hasn't been a part of any conversations that I've been in the work on our workforce, task force, and some of the work that we have been engaged in. But I think that understanding the root causes of why people are leaving the profession and what's going to retrain and attack folks, there have been a lot of things put on the table and decisions that have been made to ensure that the campaign to increase the workforce is successful.
Because I remember we received testimony specifically about emergency rooms in hospitals around the holidays, and the paid leave legislation was implemented, and they were having trouble staffing emergency rooms during holidays and things like that because employees were utilizing paid leave, and it was threatening the operation of emergency rooms. It didn't come up in your presentation today. 3 years ago, it was the headliner for hearings here in Annapolis. I remember them, wasn't that long ago. And I believe it was prior to COVID, but my memory gets foggy sometimes. But I appreciate you entertaining that. And
Yeah.
if there is any information on it, that'd be interesting.
We can definitely look into that and see what we can find and how that relates to the current efforts, ongoing efforts.
Appreciate that.
Yep.
And thank you, Madam Chair.
Thank you, Senator. So it's my turn. First, I want to thank both Brian and Dr. Rebacher for not just your presentation, but for all your work as we worked in this work group. And so many issues came up that it's pretty overwhelming. But I have a couple specific things that I didn't hear today that I heard in the work group. One of the things is kids that need behavioral health, need to be admitted somewhere for behavioral health issues. We don't have facilities, and there are also boarders in the room. So is anything being done to try to provide more behavioral health opportunities for kids that need to leave the ED and go somewhere else for service?
Yeah, there have been some legislation, and our partners from the behavioral health space have raised some of the legislation that passed, I think, last year. And forgive me, I can't recall it right now. But we have discussed efforts to build on some of those resources. And I do understand that the HGO is looking at some efforts around behavioral health bed expansion, particularly for the youth. And so more to come on that. But that is a very pressing issue, as you can imagine. And it's something that is really critical to this work.
Thank you. My next question is about when we have patients, particularly mostly elderly patients, who need to be moved to rehab. And I've had this experience, Dr. Rebacher knows, I've had a number of seniors in my family. So it seems to take at least 3 days once the hospital decides that patient needs to move to rehab to get a facility that will take them and move them. Is that continue to be a problem, or are we working that out?
It continues to be a challenge.
Okay.
I think, the workforce challenges aren't isolated to hospitals. And so I would imagine our post-acute care partners are also feeling some of those challenges. I think there is also conversations around the process by which we get authorization and how to get a patient to a post-acute care facility. There's opportunity, there's active discussions in our work groups of how we can hopefully help address that with all of you as well. It continues to be a challenge.
So is it Medicare that requires a 3-day stay before they'll pay for rehab? Or is that a state regulation?
If I'm not mistaken, that is a Medicare regulation.
Medicare.
And it is something that, as Dr. Rebacher said, something that we have discussed extensively. And there are, opportunities to address that through some decision-making that you all can probably support.
Okay, I appreciate that. I mean, when we talk about this bed shortage, if someone's staying 3 days longer than they need to, that's a lot of beds,
Yeah.
which that's my next question is beds. So not only do we need beds, but are they in the right places? Like I heard Dr. Santa talk one time that it's not so much that we need more beds, we need beds in the right places. So your chart doesn't really show us that, but I understand that when the new Capital Region Hospital was built, it didn't get the number of beds that were requested. We're like 100 beds short. So do we know where the beds are that we need? Are they in the right places, or do we just need more beds in general?
I wouldn't want to to indicate any potential solutions that haven't been discussed or that might jeopardize the goals of our model and the successes that we've made on that. You know, I think the consensus around the field, around the hospital field, and also with our partners in the state is not necessarily that there's an overall shortage of beds, but that we do need to look at the supply of beds and the utilization trends in different areas around the state. As you can imagine, you know, just with the ways that residents move around the state, inside, outside, hospital utilization also moves with the flow of residents. And so that is something to look at.
Thank you. I look forward to continuing to work together and hopefully, provide you with solutions that you need. And thank you again, both for your work. Any other
Absolutely.
questions before we end this briefing? Thank you very much.
Thank you so much. Thank you all for your interest.
Thank you.
So next we have John Crome from the Health Services Cost Review Commission, HSCRC. That's a lot easier. Thank you.
Easier to move this over? Great. Madam Chair, Madam Vice Chair, members of the committee, thank you so much for, let me see if I can advance this. Oh, other arrow. Thank you so much for the opportunity to come and talk a little bit about what the HSCRC is working on. This is absolutely a critical issue for Maryland patients and for our hospitals, and certainly has been a focus area for us at the HSCRC over the last few months, and so excited to talk a little bit about where we're moving here. So first, we've talked a lot about this in the previous panel here, but again, what is the extent of the ED wait times problem? And I would say, as we think about ED wait times, we really do think kind of broadly and systemically about ED length of stay, right? So ED length of stay really representing the amount of time that a patient is spending, in the ED, which is beyond just the wait time. It's also the time that they're receiving care, right? So as we can see, that is a very complex, multifaceted problem. We have historically been, for a very long time, over the national average, significantly over. And you can see that historical trend has stretched certainly well before the current Maryland total cost of care model, and as far back as our data collection goes, right? So all of that, I think, indicating this is a complex problem with a lot of contributing factors, right? So over the last few months, we've been doing some modeling work as we gear up to look at how we are going to build some incentives around managing ED length of stay. What I want to highlight here is that in that work, what we're seeing is that there's certainly impact that can be driven through hospital level interventions, right? There is operational work that Dr. Vibakar described that is, I think, going to be very, very meaningful and impactful in improving ED length of stay. But there are also some factors that exist outside of the hospitals or are structural factors of our hospitals, right? So for example, Maryland hospitals, for a lot of reasons, for a lot of intended reasons, right, about improving the efficiency and quality of the delivery of care, Maryland hospitals tend to be larger and more complex, right? We have academic medical centers here in the state, and that does tend across the nation to lead to higher, to be correlated with higher ED length of stay. Bed size, complexity, teaching status, ED size, all of these things contribute. But then one of the points that Dr. Vibakar described, hospital occupancy is a really critical factor, right? So when we think about hospital occupancy, there are a lot of levers that we think can move, right? Certainly, inpatient length of stay is one that we are particularly focused on, right? And I'll come back to that in a moment. Managing things within the hospital like access to palliative care, right? Managing end of life care in better, more effective ways. We've talked a lot about post-acute care access. That is a major challenge, right? That we're seeing as I tour ED and meet with ED leadership teams. That is consistently something that we're seeing, and we can see it in the data as well, right? So all of that leads us to a set of potential policy approaches that we think can be really impactful on ED length of stay over the long run, right? Again, some of them I've mentioned, some of them exist within the hospital, improved palliative care services, right? Some of the operational improvements that we're really focused on in the EDDI project. Improved behavioral health access in the community certainly is a contributing factor when we look at Maryland ED length of stay. Improved SNF access, again, that is a high leverage a point of access, I think, when we think about improving ED length of stay. And a lot of these factors really, again, get to improving systemically how patients move through the hospital and then out to ultimately where they should be discharged in order to get the best care possible, right? Again, improvements in primary care, right? So in other words, avoiding potential utilization, right? That could be avoided if they have access, if a patient has access to primary care. And certainly, you know, one thing that we have not talked a lot about, addressing social determinants of health to make sure that those patients' needs are being met as well. So all of this together really starts to paint a picture of a couple kind of sets of initiatives, right? One set is, again, the operational things and things that we can control within the hospital. But I think I'll also talk about our partners at MDH as well. I think we are collectively thinking about this really in terms of population health, right? And so we'll talk, we've talked a lot about hospital beds. When we think about hospital beds within the context of population health, the goal is really to match the capacity with the needs of the population. So if the population needs SNF beds, building inpatient beds isn't going to help that bottleneck, right? If we need more primary care, building inpatient beds isn't going to solve that bottleneck, right? So when we think about over the long run, where we want to go in terms of managing ED length of stay, it is really aligned with where we want to go in evolving the model through the opportunity represented by AHEAD, right? Where we want to take a more concerted strategic effort around managing population health as a whole, not simply focused on just the capacity within the hospital, right? We need to, this is an all hands on deck type of problem. We need to make sure that we're building that capacity across the continuum of care. So I mentioned incentives. So historically, the way that HSCRC has really tackled quality issues and other issues that are complex within hospitals has been around designing incentives. And certainly we are taking that strategy again here. We've had a good track record under this model in moving certain really, I think, complicated quality issues. The one I would point to is, is pretty analogous, I think, to this multifaceted challenge, which is readmissions, right? So at the beginning of the model, Maryland was a very poor performer relative to its state peers in hospital readmissions. Through concerted effort and incentives provided to hospitals, that readmissions number has improved considerably. We've gone from among the very worst in the nation to the upper quartile, right? So there is, I think, a proven track record of when we focus on incentives and sustain that focus over time, we're able to do a lot of great things with our hospital partners. So, but again, we want to make sure that we're taking this approach in a multifaceted way, right? So we're in the process of developing a set of incentives, one incentive on the overall ED length of stay, right? So that's something that we have in process right now. Where that stands currently, the commission has approved us moving forward with that measure. We are working with hospital partners right now to finalize what that measure looks like. We've mentioned it before. There are many different ways to measure ED length of stay. So we need to make sure that we're hitting on the right one and that we're testing that measure, et cetera. But that is going to be put into payment in the near future. We're also looking at currently in development an incentive designed around reducing the number of multiple visit patients, right? So many of our EDs see patients over and over again, right? So we're building an incentive around hospitals who programmatically identify those patients, identify what those patients' needs are, and then help connect those patients to those needs. And we have several examples of hospitals who have those programs in place. They're getting good outcomes from those programs. So we want to make sure that we're incentivizing that so that it's adopted statewide, right? So that's another set, again, within the control of a hospital to impact. And then finally, we've talked, our MHA partners have talked a lot about the EDDI project. So through that project and through work that we're doing with other states to identify best practices, we will have a set of best practices that hospitals can take to improve ED throughput. And so we'd like to build an incentive around ensuring that hospitals are doing those things, right? So we'd have an outcome incentive. We'd have a process incentive around those best practices, right? Some of them are operational in nature. Some of them are things like, are you partnering with your local SNFs, right? In important ways. And then finally, focusing on a particular population in those multi-visit patients, right? How can you reduce the avoidable utilization there? So we think that taking that kind of multi-factor incentive strategy is going to be really impactful in the short term. On the longer horizon, because we are thinking about that population health view, right? We are working with MDH closely on how do we start to do two things with access outside of the hospital. One, how do we build some value-based programs, which we can do through our model, right? And that the HSCRC has done through the EQUIP program and other things. How can we build some value-based payment arrangements in the state to help with promoting post-acute care access, right? And streamline those handoffs, and then also make sure that those handoffs don't result in readmissions and et cetera. So it'll improve both the quality of care as well as improve the ED length of stay challenge. Looking at things that we can do on improving the use of palliative care, palliative services in our hospitals and throughout the state, the availability of hospice services, right? And then also looking at how can we improve some of the post-acute behavioral health as well as subacute behavioral health capacity in the state. And that's a lot of the work that we're doing and I'm sure you've heard the secretary talk quite a bit about. So those are things that we can work on over the long horizon, I think, to improve kind of our population health strategy around reducing ED length of stay. But in the meantime, again, I want to highlight this multifaceted incentive strategy, I think, is going to yield shorter term progress. So this is just certainly just a restatement of some of the activities that we currently have in development at the commission right now. So let me pause there, and I'm happy to take questions. Senator Washington, I do have some numbers that I can provide if you are interested, but I can pause there and take any questions.
Thank you very much. I brought this up a few times in the work group. And
Yeah.
I just continue to find it puzzling and interesting that we are the only state in the country that has the waiver, and we are 50th in ED wait times. Is there any correlation? Do you see any correlation with that?
Well, I mean, again, I think just going back to the data, we were that way before the model. So I think it certainly hasn't improved that outcome, but I don't think it is the driver of that outcome. I think that when we do think about the root causes, right, there are certainly tools within the current model, and then I would especially highlight where we can evolve the model under the AHEAD program that we have not leveraged against this problem, that I think we have an opportunity to do so. I've described some of them, but I think over the longer term, really clarifying that focus on population health is going to be ultimately where we need to be in order to move this very long-standing challenge.
Thank you. I do want to mention to the committee that Deb Rifkin, who we all have known for years, is not here today because she is home ill, and she's very disappointed that she doesn't get to see all of us today. But thank you,
Yes.
Mr. Crum. I have a
Deb
question.
Rifkin is our wonderful new director of government affairs, and she sends her regards. So.
I have a question from Senator Washington.
Yes, it's going to be a surprise. Thank you, Madam Chair. Can you give us those numbers?
Yes, certainly. So little bit of context here. Again, when we're looking at ED wait times, we're really looking at ED length of stay. So that includes the time of treatment, not just the wait times, right? So currently, through the EDDI project, what we were reporting out was that the statewide median in December for ED1A, so this is the patients that are the time between when a patient walks in the door who will need to be admitted to the time that they were admitted. So when they enter the ED and when they leave the ED. And you can think of these patients as likely the most sick patients that an ED would see. So they're receiving a lot more care than the person with a sprained ankle or, that sort of thing, right? So we look at ED1A, this measure, as a good benchmark for us because it represents kind of systemically all the things that would happen within a hospital. And so that median time in December was 567 minutes, right? So again, these are the most complex cases, right? But 567 minutes. So we would be, so that is one of the measures that we look at. By comparison, outpatient OP18A, that's a measure for the patients who are not going to be admitted. So they're going to be discharged to home, right? The statewide median was 263 minutes, right? So both of those numbers, there's a lot of room for opportunity there for improvement. But that gives you a sense for how, when you're talking about different populations of patients that are seeing the ED, the experience is very different, right?
So the 263 is when you come in, you're admitted, but then you leave. You leave in the same day.
You're right. So you're being admitted to you're being discharged to an outpatient care, right? Or to home, right?
So the 567 minutes, that's approximately a little over 9 hours.
Yes,
And then the 263, that's 4.5 hours.
Right.
Essentially.
Yeah.
And I'm new to this committee. I'm the only Prince Georgian on this committee. We helped build the Center. Really excited about it. We thought it was gonna drive down wait times, at least wait times, not even when you get back in there and you didn't wait another hour to see the doctor.
Mm.
Wait times are still extreme in that hospital itself. What's the wait time, just the wait time to see a doctor in that hospital?
so we'd have to talk to the hospital because that's not a metric that we collect statewide, but I can follow up with you and
Why
provide.
is that? Why don't you collect that?
Well, because again, we're looking at that entire length of stay, right? Because we
Yeah,
want
I
to
get the length of stay, but why not that period where I'm sick? My child is sick, excuse me,
Yes, yeah.
and we're waiting there for 4 hours.
Mhm.
Why is that not something that, I understand the length of stay.
Yeah.
But just that time in me, because you feel better when you actually get beyond that point. It's
I
just,
agree.
you feel different. It's-
Completely
For some
agree with
reason,
that. Yeah,
you just feel
completely
different.
agree with that.
Like
You-
finally I
yeah.
made it.
You're getting service,
You're getting
right?
something, you're
Yeah.
getting something.
Yeah.
So why is that not part of
So-
your equation?
Yeah, so in part, it's a measurement problem, but also in part, different hospitals have very different strategies in terms of like who they, how they do triage and so forth. So I think as we go into our best practices incentive program, this is one of the things that we're gonna look at, right? Are there models that would put somebody in front of a provider faster, right? That may be better for care. Let's see, right? Let's see what that evidence looks like. And then if that's a good best practice, we'll get it into that incentive.
I hear you. I just think it's really unfortunate that, we as a legislature and the county, we all put over $600 million into that new hospital, built that new hospitals there. It didn't end up being the hospital that we all wanted. Obviously, we came into some stifles with the former governor. But we sold it to our community that at least you're gonna see a doctor sooner.
Mhm.
And what we're saying as a state, we don't even measure that. But we sold that to this community, that their tax dollars are gonna pay for this. And so I'm just a little disappointed that we're not even, I can't go back home and say, we're gonna decrease these wait times. But if you stay, we're gonna measure that piece. And so I just think that MHA, if you can get us some more information on the particular hospitals, because I think we all wanna know what those wait times are for the particular hospital. Because it's hard to fight for a hospital if I can't say this is the services you're gonna receive. That'll be better care, or you're just gonna see a doctor. You're gonna get behind that curtain a little sooner than the last time you went there. So thank you, Madam Chair.
Thank you, Senator Washington. Senator Hershey?
Thank you, Madam Chair, Executive Director Crom. First of all, I certainly empathize with my colleague who has got a brand new hospital and having difficulties in having that operate the way that it should to those standards, which I would agree on. At the same time, you might know Senator Moutz and I share representation of 5 counties, which only has 1 hospital in it currently. And this committee has done an awful lot of work over the years to provide a hub and spoke approach to delivering healthcare within that Midshore region. It is a little concerning to see on your slide that new hospital beds are not the best statewide solution. I'll hope that you don't mean regional solution with respect to that, because obviously there's a severe gap in what we have. Certainly we have Easton Hospital, but as you know, it's over 100 years old. And that goes back to a lot of conversations we just had recently with trying to retain physicians and staff to be able to work there. So just want to make sure that while you're here, you kind of understand where Senator Moutz and I are right now. Last week, the MHCC approved the CON for the new regional medical center in Easton. The governor has made a commitment to funding over $100 million to support that. And HSCRC is the last piece of the puzzle for a long-awaited resource for our constituents in the Midshore. So We are looking forward to hopefully a very favorable report from the commission on the rate application that is needed to help with hospital operations and to get this new hospital off the ground and make it a reality, just like my colleagues is.
Certainly, I appreciate that, and I would absolutely agree that while it's not the statewide solution, there are pockets within the state that appropriately would need to build volume, right? ED wait times is not necessarily the key driver of that, though, right? So inpatient beds would certainly track to, again, as populations expand, right? As so a lot of factors that go into that, ED wait times being one of them, right? To your point about Easton, we're working right now on that proposal. I would say just, for all to keep in mind, right? When we're talking about the HSCRC, we are talking about rates, right? So hospital rates. So that does come back to the issue of affordability. So it is something that we always balance, but certainly access is very, very critical when we think about hospital capacity. So
I appreciate that last statement, because I think that's the big issue that there are rates and they have to be able to support the operations to get there, but it is certainly a question of access. And in order to get into this position, we've certainly downsized Chestertown Hospital, where we've made that the Aging and Wellness Center of Excellence, and we've closed Dorchester Hospital and have a freestanding medical facility there. So we have taken the steps to get this all in place, and certainly access is the most important. It's up to you guys to be able to approve the rates and make sure that it's affordable as well too. Thank you.
Thank you, Senator Ellis.
Yeah, thank you, Madam Chair, and thank you for your briefing, sir. So maybe you have some answers for me from the previous panel with the say vacancy.
Yeah.
Not vacancy, but the availability of nurses, say in Southern Maryland, there's a 30% deficit versus like Eastern Shore is like 4-point-something%. I know that rural areas have different reimbursement rates of certain insurers, government programs. But do you have a take on why that large vacancy in just nurses? And I suppose it might be with other healthcare professionals also, why that exists? Do you have a view on that?
So let me caveat by saying we as an agency don't regulate provider reimbursement or certainly staffing levels, et cetera. I would say that my experience kind of working with a number of hospitals here in the state has shown that different hospitals have been impacted differently by COVID. It is an extreme challenge in a number of communities, and I think that your community is certainly one of them. So I don't know what they're specifically doing in that hospital, to kind of turn that around. But it is a challenge that I think we're seeing in a number of communities around the state.
Okay, well, thank you very much. I appreciate that. Thank you, ma'am.
If I have no other questions, that will end this briefing, and thank you very much for your work and for being here to present.
Thank you so much.
So committee, we're going to wait just a few minutes while Tammy switches over to the voting session. So about 3 minutes, Tammy, or 5 minutes? Okay. Don't go far. Thank you.